the last part of today's seminar, we have the panel discussion. Panel discussion on role of yoga in chronic disorders. And may I now request Professor Amirtha Ganesh, Sir, HOD of Cardiology of Mahatma Gandhi Medical College, to give the clinical perspective. Please come up onto the dais, sir. I am reading in the order that has been printed, not in the seniority or anything, so please come up. The community perspective would be given to us by Professor K.A. Narayan from the Community Medicine Department of Mahatma Gandhi Medical College. And another clinical perspective on pulmonology would be given to you by Professor R. Pajanivel, Pulmonary Medicine of Mahatma Gandhi Medical College. The research perspective is to be given by Professor Madanmohan, sir, Honorary Emeritus Professor of CYTER, and the nursing perspective should be shared by Professor Renuka K, the Dean Faculty of Nursing of SBV, and the yoga therapy perspective, of course, I'll be there. And the whole panel discussion is going to be moderated by Dr. Ananda Ashram, Director of CYTER.
I think you will agree that we also have very nice food for lunch. So on both sides, the body, the mind, the emotions, the spirit have all been nourished. We would like to take today's event forward with this. You know, there's a thin line of difference between sound and noise. And another further aspect is music. And we often say what is music to one person is noise to another, and what is noise to one is music to the other. So once our mics decide whether we will be noise or music, I think we go ahead with this. We have a very eminent panel today, and we felt that we try to make it as interactive as possible rather than have many small presentations, that we have a very beautiful panel. We have Pajanivel sir, who's going to be giving us aspects from the clinical side, especially the pulmonary medicine. And similarly, we have from cardiology side, we have Professor Amirtha Ganesh. And Professor Amirtha Ganesh should have enjoyed Amma's presentation, because he is at heart a musician and a singer. And he actually is a doctor, a cardiologist who sings to his patients. And then I think he makes them sing. So they have nice singing in cardiology. So he would have enjoyed the power of the chant, I'm sure, a lot. We have Professor Narayan sir, who is going to give us the social aspects, because sir is coming from the background of preventive social medicine, community health. And in chronic diseases, we are not limited to just the individual, but the whole family and the society is involved. So we felt we would like to expand our perspective. Of course, we have our Bhishma Pitama of CYTER. Sir is wondering who I'm talking about. It is you, sir. And Madanmohan sir is going to give us some of the inputs on the research angle, because sir has been right from the 70s, been into the field of yoga research and physiology, and going to give us some of his experiences and knowledge. And you know, when you talk about chronic disease, not just the individual, not just the family, not just the society, but all of us need care. We all need love. We all need nursing. And so we felt that the nursing perspective can come from Dr. Renuka, who is the Dean of the Nursing Faculty in our university. And of course, last but not least, the lady of the show, who has been from the morning keeping the mic going. You know, Dr. Meena is going to be giving us examples of how yoga and chronic disorders we have been facing at CYTER, because she has been here right from day one, November 1st, 2010, and dealing with patients starting in the individual, few patients becoming dozens, hundreds, and now we are touching close to 40,000 patients in the last now 7 years here. So a huge number of people benefiting through the work, so she'll be sharing that. So the moment we say chronic disease, the question comes, what do we mean by this? And I would request Professor Narayan sir to start off this panel by giving us an overview, what do we mean by the term chronic disease?
Thank you, Dr. Balayogi, for giving me this opportunity, and thank the organizers too. This panel discussion, and in fact when we said chronic diseases and perspective, the first thing came to my mind, do I have an understanding of this myself? So obviously I didn't. When I looked at it, chronic diseases, even the world bodies have not come to a conclusion as to what to label as chronic diseases. So the definition itself, when the professionals are confused as to what we should call as chronic diseases. And therefore, when it comes to the general public or other, I'm talking of the medical field. When we talk of the other disciplines, related disciplines, I'm sure they also would have a lot of confusion. But the World Health Organization, taking that being the leader for most of things medical, they took the lead in trying to define what could be chronic diseases, and they have come to some sort of consensus to say that it is something which is of long duration, usually which leads to more than 3 months. But then that's easy to define. Anything which somebody suffers for more than 3 months, you can call it a chronic disease. But then what is the chronic disease? So then again, world bodies have sat together. Major bodies, as again World Health Organization, the other major body is the Centers for Disease Control. They could never come to a consensus, but they said, okay, let's at least narrow down on what could constitute chronic diseases, and many have come to the consensus that 4 diseases should be considered whenever we talk of these. One is cardiovascular disease, and which constitutes of heart attack and others, then cancers, chronic respiratory diseases, including asthma and diabetes. Others, like Centers for Disease Control, have listed up to 20 major which take up the burden. But if we start listing, actually it can run into quite a number of diseases. World over, if you have to take, these are the ones, the 4 which I listed, are the ones which take up the major chunk of what the term used is DALY, that is Disability Adjusted Life Years, a measure of how much it damages or how much it impinges on people. So that if that is taken as a measure, then these 4 diseases are taking up the major cause for one, the morbidity or the disease process itself, and also of death. Again, contrary to what has been going on here, we are back to medicine, where we're talking of illness rather than wellness. So I think that therefore, we have to take this with a pinch of salt. Now, how many people are free from this probably should be the focus, or at least make them free from disease. I think if that defines that, we'll start with the ball rolling with this definition. We have a difficulty in definition. Again, it's easier to define that we have the disease rather than say that you don't have these diseases, whereas that should be our focus.
And I think it's a very valid point that sir has brought up. And as you all know, at Sri Balaji Vidyapeeth, the whole focus that our Vice Chancellor has been taking us on the last few years is salutogenesis, and how to look at factors of health. And this is where I think when we talk about chronic diseases, what we are looking at is that there's been this movement away from health. How can we help people come back to a state of health within whatever they have? And I think this is why it is very important to start understanding this bigger picture. Maybe Amirtha Ganesh sir can just tell us a little bit from the cardiological clinical side when it comes to these chronic disorders, what is happening?
I look at this in 2 aspects. One, the patients suffering from the ailment chronically. Textbooks say that cardiac failure, when you have an ejection fraction this much, they will live up to these years, all those things. We find it very difficult to define. For example, patient with the cardiac failure, immediately the family will ask how long he will live. Then it becomes very difficult. Then like Western books, we cannot quote 65% of them will live up to 80 years. That 50% chance that they will live up to 10 years is totally, it's confusing. So we are not able to define how long they live. Everything burns down to that. So people suffering from the disease, how we are going to help. Number two, in patients in whom the cardiovascular risk factors are silent, which they will burst at one moment becoming a chronic disease. Third thing, non-cardiological factor affecting the cardiac part.
Okay.
So I view in two different views, all these things combined together in a preventive aspect and in a rehabilitative aspects. Treatment is different. We know when somebody says yoga therapy, there is some therapy. But I look at it in two aspects. One is preventive aspect, another one is rehabilitative aspects, which is missing in most of the institutions in India, which they find it very useful in, especially Europeans.
Yeah.
They have 6 weeks of rehabilitation therapy. In terms of preventive therapy, I want to just highlight only one study which I did in institute. For the 5 years, we know all stress, we know when you list out the factors for cardiac diseases, hypertension, age, blah, blah, blah. One small word is mentioned, is stress. What is really stress? Everywhere when I go, sir, tell something about stress management. Why should we manage stress? I don't know. But still, I found in the study, 17% of drivers, I took only drivers as occupation, young, especially I studied heart attack patients who were young, less than 45 years. The total incidence was 17%. Out of them, 50% were non-smokers. 50% were non-smokers. So something other than smoking in drivers, it is there. When I went into the history in depth, probably food habits, all those things are there. But still, many of them were stressed. So many of them I felt could have been prevented. I find it's every one of us, we have stress. Even for in cardiac department, when you come to the OP, I have lot of stress daily, multitasking. But still, I manage in some way to handle it. That's what I mean about.
Very much.
So chronicity helps there also.
Very much. It's very interesting here because it all seems to ultimately boil down to stress. And again, stress is so much about how we as an individual can respond to the environment around us. And I think, we'll ask Pajanivel sir next because how does this, yes sir, the word stress came, so naturally Madanmohan sir has to say something about it.
A pure point, and that smoke itself is stress for them.
Yes.
And sometimes, if you are suddenly exposed to very heavy smoke, it can create hell, it's a chemical stress. Stress is meant we're talking mostly of the psychological stress. It's a chemical stress, physical stress, heat stress is there. And also that, the preventive and the rehabilitative, curative is also very important for cardiovascular. We see in the Japan, the last PhD thesis, that yoga improves the ejection fraction. That's the PhD thesis. That's fine. That's also there. And also the yoga can modify the risk factors. One of the direct curative effect. Risk factors are modified, like blood sugar, which are cardiovascular risk factors, blood pressure, they're the risk factors. That's also there.
I think, one thing is that we would like to ask Pajanivel sir because we often see that, people have these long-standing lung issues, but again, people like to deny it, I think.
Yeah.
So I think maybe sir can give us some light on the chronic conditions that come.
Sure. Very good afternoon. It's a pleasure to be here, and I thank the organizers for giving this opportunity. Talking about chronic respiratory diseases, from a clinical perspective, usually the definition goes anything which is more than 6 weeks. Okay. And we are quite happy with these estimations because...
More patients.
Yeah, more patients, and my monthly income is regular. Right. So, sitting in my clinic. Right? So, but looking at the other aspect of it, humanistic point of view, right? And it's unfortunate that WHO has labeled respiratory disease one of the 4 major chronic diseases. That's because, the lifestyle is changing, the world is changing, and of course the stress is one important factor. Breathing is my breathing, and of course it's yours also. So only thing you make normal people breathe better, I make abnormal people breathe slightly better. Okay, right. Okay, so we fail in that also. The point of concern is here is the treatment of chronic respiratory diseases even as on date is not to cure the disease. We can just control, we can just delay the progression of the disease. At any point of time in his lifetime, the patient is going to a point where he cannot come back. So this is what is the real stand scenario now. But the ray of hope as of now, though it's an ancient practice, yoga in a different form of a scientific discipline has shown some light on this quality of life on these patients, and it's fortunate that we have a CYTER team here supporting us in major respiratory diseases. So this is my initial point on chronic disease.
Actually, I would like to add that thanks to Dr. Pajanivel sir's interest in working on this field, we actually have currently 2 MPhil dissertations running on work of yoga and pulmonology. So it shows that actually there's a lot of work that can be done as we go forward. Similarly, we have a work with cardiology also, which is in combination with CYTER, our music therapy. And it's something that I think this has to grow, and that is why the whole topic of today's workshop was kept like this by our Vice Chancellor, so that we would start seeing where more we can collaborate and take it forward. Now, the moment we said stress, I was just thinking, we always talk about the psychoneuroimmunology and psychoneuroendocrinology.
Psychoneuroimmunology.
And it seems to have a major role in chronic diseases. And so maybe some light on that for the participants.
Can I just add
Yes.
one? When I was listing these diseases, there's one which some others have mentioned, which sometimes gets hidden. That is the chronic kidney disease.
Yes.
Because of the others,
Yes.
chronic kidney disease is now slowly becoming a major issue, whether it is lung, whether it's cardiovascular,
Yes.
finally diabetes or hypertension,
It all ends up.
finally it also kills the kidneys.
Actually, nowadays in Pondicherry, in many of the cars in the back you will see, to avoid kidney disease, keep your blood pressure 120 by 80 and your blood sugar less than this. We actually now start to have that on the back of cars even. Yes, sir.
As far as the chronic respiratory disorders now, bronchial asthma is a chronic disorder, and yoga does help a lot, no doubt on that. And in initial stages and later stages also, because I have experience on that. If you talk about COPD, obstructive lung disease, yoga may not cure. But see, by improving the complaints, elasticity of the lungs, the muscle strength, in short, the lung function, not the disease I'm talking about. If lung function is improved, it will improve this, at least the symptom of the feeling of the patient. The disease is still there, but symptom will improve. That is such a big thing.
Yes.
That is the contribution of yoga. And of course, in addition to that, yoga in general condition, the quality of life, there's other thing. I'm talking about the respiratory itself. Complaints, muscle strength, you can hear a lot of improvement.
So definitely the person
And particularly when he cannot do anything to me, but we can do. That's the point.
Just add one point in.
This is supposed to be a cordial discussion.
We do accept that the clinicians have failed in the management of COPD because we don't have a drugs, as I said, that doesn't stop the progression. In fact, the goals of management for us is only to improve the symptoms, improve the quality of life, reduce the exacerbations. But the ultimate is decrease the death, it doesn't happen. So, but by integration,
Yes.
definitely. And that's the reason we believe what we call as the GOLD guidelines, a global initiative for obstructive lung disease. In the latest 2015 onwards, if you see the last chapters of the guideline, they said yoga can be added to the pharmacotherapy in patients with chronic obstructive pulmonary disease. So this is an international status which has been given to yoga and meditation also.
Yes.
Right.
I think here, it's again one very big positive point here at Sri Balaji Vidyapeeth It is not either you or me, but it's us. And I think this is a very important aspect of taking it forward, because often Madanmohan sir used to say, he said the limitations of modern medicine are the strength of yoga, and the limitations of yoga are the strength of modern medicine. So when you bring them together, both the limitations can be limited and the strengths can be enhanced. And I think this is what we see a lot here. Now I think I will ask next Dr. Renuka, because one is, the patient feeling better. The second is, okay, these parameters, say the lung function, or, the ECG looks better, or the, scan looks better, and things like that. But then there is a point where the person actually doesn't know what to do. And that is where I think the first line of defense, or is it offense, in our medical setup is the nursing. And maybe you can give us some light on that side.
So as in beginning, I would like to thank the organizers for giving me this opportunity to be here as a panel member. And as Pajanivel sir has said, some few people have asked me whether nursing colleges will be closed, or nursing, what will be the future of nursing. When I said, when we become a disobedient person of environment, we have become the disobedient of environment. That means divert across the environment. That is how our lifestyle begins, no? So the lifestyle related, when we go beyond the nature, when the lifestyle diseases occur, till that leads to chronic diseases. Till those chronic diseases are there, hospitals will remain, doctors will remain, and nurses will remain. So we nurses, nursing colleges will train the students for this. So this is the thing as nursing college dean, I would like to say. And then as like a humanistic person, having the social responsibility for the patient care and things like that, chronic diseases in the preventive line and in the curative and in the rehabilitative, nurses are the heart of it. Because we give counseling and the knowledge regarding the chronic illnesses, how to prevent, be it arthritis or cardiac disorders or asthma, respiratory, whatever the diseases it may be. So as we stand in the first line to give education and awareness about the chronic illnesses and the health-seeking behavior, what they are as sick role behavior and health-seeking behavior, the difference between those, and how to do certain, like how to take the drugs and what doctors prescribe. And we give a lot of, we have also done doing discharge counseling with for the current technology with ICT-based counseling. So then it's out of preventing diseases and also rehabilitative aspect, where we play important role. And we, talking about the role of yoga in chronic illnesses, as second part, I think it will be in panel discussion. But here we have vision on this, and we SBV has initiated to integrate yoga therapy education. That means for hypertension patients, what could be the yoga given? For diabetic people, what could be the yoga taught? So these aspects of yoga therapy education, though in controversy, we have taken it up as CYTER department and nursing college have taken it as a risk beyond the nursing curriculum, we have taken it up. So we'll see as research, after 2 years, we will come with the outcome, how this will work out. Integration of yoga in nursing is now happening in SBV. That is what I would like to say. Thank you.
I think one question also that comes up after listening to Dr. Renuka is that when a person has a disease, especially chronic, how does society perceive it? Because we, man or woman, as a member of society, what happens the moment somebody is diagnosed with a chronic disease? What happens in society, and how does this also impact social health? Because health is not just physical and mental or emotional, but it's also social. So I think maybe a few lines.
As from self, we get detached. When a person gets diagnosed with chronic illness, that particular person gets detached from the environment. One thing, even from the family, having a big responsibility, that also gets detached. And as society, people see the productivity of the individual, and the networking also get slowed down. And also the social neglect. Even in certain diseases like HIV, having a chronic symptoms like, so those people are getting neglected. Even stigma plays a role. This person may not fit for this work. So like that, social detachment comes from the society view and also self view. It is health how we perceive it. Though with chronic diseases, we can even still have a productive life. This is how we take the health as. Though with chronic disease, the definition of health may be merely the absence of all physical that, this and all. But how as individual living with the chronic disease, how productive we elicit, that is what the health is concerned. So in that case, if being a chronic disease, people like I have studied a review when I browsed for this panel discussion, I have reviewed like HIV positive people are more like adjusted with the life, productive life than the HIV to be like high risk behavior people to be maybe diagnosed with, like not even knowing the diagnosis, but than the HIV positive people. So this is how the HIV positive people taken it up as the productive living, and this is how we feel individual, and based on that the society also view in different way.
As soon as Madam brought out about HIV, I was reminded many years ago in JIPMA, we organized a workshop on the role of yoga in HIV and AIDS as part of Pondicherry AIDS Control Society. And I remember at that time we were looking at literature, and there was a study that showed the immunity actually improved after massage therapy. It was an interesting study. And I said it's not the massage that is improving the immunity, but the fact that another human will come next to you, touch you and give you a massage. So this is where I think again that psychoneuroimmunology part, that somebody is willing to accept you as a human being, whereas in normal society what is happening is we are shunning people. And if somebody has a chronic cough, immediately we are like, we stay 2 feet away, or suddenly somebody falls ill, we are always worried about keeping that space so that we don't get involved. And this is, I think, one of the issues that comes up in the healthcare professions, because we have to deal with them. See, somebody on a road can keep that gap, somebody in society can keep that gap, but in health professions, we actually deal with them. And I think this is where that interpersonal relationship is so important. And maybe Dr. Meena can share a bit about that importance of the interpersonal relationships that come through the yoga therapy with patients of chronic diseases.
When patient come to CYTER, the first thing that we do is have a frank talk with them. And I think talking with them by itself is a therapy for them. So half of their problem they feel it's completely gone. And like there is a perspective. They are like having blinkers. So it is their problem, so they approach it only from one particular angle. And when they expose it to us, when they share it with us, and we are able to see the other side of the problem, and we are able to give them another angle to which like they can approach this problem or attack this problem from, and that becomes a solution by itself. And even while discussing, when they are wording out a problem, that itself becomes a solution for them. It's like they are able to speak about it. They might not have even given so much of importance thinking about it, but when they are expressing that to like you or me or in the department, that itself becomes a solution. They are able to find out what the actual problem is. Till then they wouldn't have been able to identify. But now that the problem is identified, the solution becomes easier for them. It's like a let out. It's like a let out. And going back to the question number 1 that you had put, all the list of diseases that they had brought about, when I was going through all the list of chronic diseases, it was very interesting to know that ADHD, the attention deficit hyperactive disorder, cerebral palsy, CKD, like Sarah told, and the BPAD, the bipolar. All these were also listed among them, and we have had people who have come to CYTER with all these problems, and to my knowledge, I think they are all managing the problem very well now. At least a stage better than what they used to be. And there is a tremendous improvement as far as the cerebral palsy. The children with cerebral palsy that we've been dealing with at Sadeh or the other special schools, they have had tremendous improvement. See, at least they have become more independent, that they can manage their own things, without depending on the others. So that is a kind of wellness factor that yoga has been able to give them. And regarding CKD servicing, we right now have a study going on. It's a dissertation project for one of the PhDs. So fingers crossed, we still haven't done the analysis. Hope there something very good comes up. But as of now, what we have found is that the blood pressure of the patient is coming down. Both the systolic, diastolic and the heart rate is coming down. Yes, CKD. So we just hope that at least the medicine, the action of the medicine, might be enhanced with this.
I think speaking of that action of the medicine, one of the things that we often find, and I thought I will ask our clinical view on that, is when it is a chronic disease, the patient initially for maybe a month or two will take the medicine. Then after that, there are two factors that come in. One is this realization, for my whole life I have to take this medicine. Then the second realization is the amount of money it takes. And the moment these two come in, there is a tendency for the person to start skipping medication. And then the third aspect is when the side effects come in. So one is the fact that, I have to take this for my whole life. Oh me, first point. Second point is going to cost so much. And third point is the side effects that are added. Now, what happens normally in a normal situation, leaving yoga out of it, how would we deal with it clinically? Because as she said, one thing we find is that maybe the yoga helps the person become a bit more compliant with the medicine.
Yes.
So, is there any other way we can work on it? It was just a...
Yeah, I think that's a very crucial point of clinical practice. Once you diagnose a patient with bronchial asthma or COPD, we say this is something like a diabetes or hypertension. We use those examples to say this is lifelong. And we also say this is not a disease, it's probably a body tendency or something. You develop an hyperinflammatory state, so you need to be on drugs which reduce your inflammation. And as you rightly said, till they get relief of their symptoms, they are on the proper track.
Yes.
But after 3 months, again, they come for consultation. But when you see the canister use, if you are in inhalation therapy, they would have stopped so many doses. They always say, I was feeling better, why I should take the drug. So that is a common excuse. Cost is of course an universal factor. I don't think anyone can deal with that in what form of therapy. But getting into the compliance again and making it adherence, I think focusing on alternative medicine or complementary medicine, telling them that if you go for this, maybe we can reduce the dose. And if you continue the same dosing pattern, maybe we can reduce the dose and at point of time we can stop also. Right. There are a few interesting examples which I want to share with the audience, because especially in mild asthma, patients come to us initially with mild asthma. We see the FEV1 is between 70% or 80%, but still they do have symptoms of wheezing or allergic rhinitis. We put them on inhalation therapy, they are absolutely fine after 3 months. There are quite a few patients who drop treatment. Of course, it's not recommended. But after 2-3 years, when the season changes, they do come back again with the same symptoms. I asked them, what has happened over the 2 years? Stop the treatment. We had advised you to be on treatment. They said, I was better with yoga.
It is interesting.
Though it is, we feel insulted. We do really feel insulted. I never gave you yoga therapy, you went for yoga therapy and you never followed my advice, don't ever come back to me. But analyzing the truth, probably yoga therapy, what that patient was right. Meditation and yoga therapy probably would have balanced the immune system so that she never had any symptoms. So there is a truth hidden in that. So definitely in modern medicine we try too many avenues or methods to make the patient adherent or compliant to treatment. It has failed. Maybe this is one option for making the adherence.
Actually, this this concept of the immune modulation, I think that is really some place where not much work has been done, and I think is a place that can be taken forward, because if the immune system is modulated, you're going to modulate most of the responses that are coming in these disorders. Yes.
Addressing your, these two questions which you asked about the long-term medicines and cost, both are true. For that, what I've been following is that, especially in youngsters, now I am seeing for the past 8 years, at least in per OPD, at least 2 patients I get, including doctors, age less than 40 years, with a BP of 160/90 measured somewhere. Somebody immediately will start on some beta blockers, whatever it is, which I disagree. One small comment about even the recent trial, sprint trial, which has told that no, your BP should be strictly 120/80. Dr. Shobana will agree with me. What BP we are measuring? Actually, the BP measurement itself is a fallacy. And the sprint trial has clearly shown that in those patients whom they were using 4 drugs for control of BP, they had more side effects. We can't afford to do that to our patients. Suppose a patient takes 4 drugs and BP falls to 100, if he or she has a syncope in the road, think of him. So, yeah, so truly I am not in agreement with the targets which they fix. First, I try to withdraw. In our own institution, I have at least 4 doctors in hand, whom I have minimized the drug from 4 to 1. In many of them, I have stopped the drugs. With one BP recording of 150/90, don't come. Please don't come. There, I use alternative therapies. Yes. It's really useful. So that we can prolong them without any drug therapy for another 10 years. I feel many of the targets of BP are not quite useful really, and it is not turning into a clinical benefit.
I think this is one of the issues recently that we have been focusing on, is how the so-called normal values have been lowered. And there's a lot of talk.
Who lowered normal values? Are lowered by the drug companies. They decided. That's very clearly known.
Because see, the moment you lower the normal values, everybody becomes abnormal. So this was one question that has always come up. And again, going back, we go back in one way, because the whole Indian system of medicine was personalized medicine. It was always based on the individual. Whereas the modern medicine was generalized, but now modern medicine has moved towards personalized.
I hope so.
Well, they are trying pharmacogenomics, and we are trying to move towards it, because each individual, as I'm sure Madanmohan sir will also go with this, each individual needs a different level of blood pressure or blood sugar for them to function normally. Now the problem is, again, the common thing is we talk about averages.
Yes, sir. One comment here.
Yes.
Important comment. I have at least handful of patients in the OPD where their normal BP is 80/60. And they are doing very well.
Yes.
See, we need pressure, no symptoms, absolutely no symptoms. Cardiac failure, I could optimize all the drugs for cardiac failure. Yes. But the only thing I realized now is it's only the mean pressure. Some pressure you need to push the blood into the brain, that's all. It is not the absolute values which is important. So I have some disagreement with these targets, the so-called targets. In that way, this ambulatory BP is very useful, and the alternate therapy you can see your treatment response. At night, your BP has to drop a bit, which is very useful factor in identifying whether the alternative therapies like yoga or music is helping them to bring down the
dip.
Yeah.
On the flip side, I have got friends who say my normal BP is 140 because if I bring it lower than that,
Yes.
that I feel uncomfortable. Doctor may say anything, but this BP level, I'm comfortable with that.
It's
That's the flip side. Couple of points I'd just like to make. First of all, coming again from the societal perspective, the first question anybody asks is, why me?
No.
He was trying to mention that it's very difficult to explain to them that you have a 10% risk. But the first question they would like to get the answer to is, why me? I'm perfectly all right, that person is similar to me, but they have not got. This creates a lot of problems, especially when, leaving aside HIV and No, that's a different set of things, but if you talk of diabetes and hypertension and the common asthma, the issue is there's a degree that society itself sometimes does not accept. For example, cancer, I've had several instances where even very recent one, where the patient goes back to the hometown after treatment, the people who used to help them out in the family, suddenly they stop coming.
Yes.
But that's a major setback for the individual.
It is.
So I think the society also has to view many of these diseases in a different perspective. I have had another instance quite some years ago, about 20 years ago. Once they were diagnosed as cancer, they wanted to sell their house because they couldn't meet the expenses.
Yes.
People negotiated. The next day they found out that cancer, they said they dropped the price by half.
Sure.
And the relatives wouldn't come to help the people who are coming. So we do not really, we talk of HIV as a stigma.
Yes.
People don't touch. So, but one thing about all these diseases, both the preventive aspect and the curative aspect, all we need to do is address a couple of things. One is tobacco use, avoid that. Avoid alcohol, look at your diet and do regular exercise. Now, especially for the preventive aspect, regular exercise, and what better way of doing a regular exercise than if we can inculcate the habit of yoga in them. So that's why probably Dr. Pajanivel gets upset, because he is just doing exercise. So don't take it as yoga. Somebody who is not doing it.
Parasympathetic lifestyle, as today K.K. Agarwal sir is saying.
So the others, of course, control of hypertension, raised blood glucose. The WHO itself has said that all these illnesses can be tackled or prevented by using these strategies. And if we promote a healthy lifestyle, and in that built-in yoga we have achieved a lot. Yoga is one method. It can be any method, but yoga has a definite advantage over the other what are called the aerobic exercises. That this has got several other advantages. It controls the mind.
Actually,
Sorry, sir. On the lighter side, there are a few people who are really happy to be saying, I have diabetes, I have hypertension.
Yeah, because
they feel proud to be saying, and they sort of, associate themselves with that disease. My BP, my sugar levels are higher. So that is another side of the society again, when we are talking about the social angle.
actually, this is one of the...
I'm always asthma or go club.
Rich man's disease, is it?
Actually, this is one of the main points we often talk to our patients in the yoga therapy clinic, is that this identification with the disease. Because many of the people, when they come in and you say, good morning, who are you? The first answer they say, I'm diabetic. And you are like, at least you should say your name. But it's first is, I'm diabetic or I'm hypertensive. And, they are so identified with, I am a diabetic, I am a hypertensive. This I am, that I has become this disease. And, it doesn't matter what therapy you use, it's not going to control it because it's to do with their identity. And I think one of the first things we tell them is, first of all, say it is the disease, not, and get it out of the house at the earliest. I think, a few of these psychological aspects are what the yoga can give us quite strongly. I don't know whose mic that is, maybe mine? Yes. Actually, when we are talking of hypertension and, again, being long-term, I think Madanmohan sir would like to share something.
Question?
On hypertension being long-term.
Long-term?
Yeah, once a hypertensive, always a hypertensive. Medicine.
You want my personal experience?
Yes, sir.
No, actually these chronic disorders, okay. I am hypertensive, I am not hypertensive since 1985. Since 1985, how many years? I did take hypertensive medicine for maybe sometime 1 or 2, 3 weeks, 2, 3 times. And my own student, I won't say name, Jipper, very important post. One day he shouted at me, you are refusing, you are not taking my medicine. You are refused your hypertension. I said, no, I'm not refused. I have, but I wrote, should I take medicine or not? That's the point. Because my BP, now also 120, 80 also comes. Less than that also. 140, 90 also goes. A little higher also goes. Once in a while, I like to feed it. Now the question is, now you have some weight. It's for you. I say, his BP, my blood sugar, he's like that. This is your weight. If you come to my weight, then something wrong with you.
Yeah.
If I get your weight, then something wrong has happened to me. Isn't it? Same, why not? Because it's normal.
Interesting.
Normal. So why not same thing for the BP and blood sugar also? Isn't it? Now the other one point. If you have now, what is your borderline hypertension? Should you take drug or not? If you take drug, blood pressure will be lowered. And blood pressure is a risk factor for cardiovascular problem. There is no doubt in that. But then drugs are a risk also for some other problems. So both things have got positive and negative. Now what to do? If you take drug, you are improving BP and reducing risk factor. If you are not taking drug, then if you are taking drug, then problem of the drug is there. Who will decide it? See, it is not an exact science. It is the wisdom of a physician. And physician cannot give wisdom unless he knows yoga also very well. Isn't it? And I know physicians have got very poor knowledge, general and practical, even 99% about the diet. They say diet means take chicken, finish, that's all. Isn't it? So they don't know lifestyle. In America also, the physicians, more than 10% they prescribe, they will not give first time the drug, they say lifestyle first. But India, we never do it. And even 10-20% American physicians, they practice at TM, transcendental meditation. So they will experience, they can prescribe.
So when you said lifestyle, like in chronic disorders, what are the type of lifestyle changes that we should bring in?
Lifestyle. So just now there was some aerobic exercise and something else was there.
Yes, sir.
That point also came just now. I have seen a paper myself. They have done, it was, I don't know exactly for what purpose. This was the mental activity, performance test for normal people. Aerobic exercise, running and yoga. Yoga, physical yoga, not the actual with meditation. Just say asana only. They have seen difference. Yoga was much better than this. They have seen that. Physical point also. Because even if you do ordinary physical yoga also, it has some meditative component is there. With breathing, a little breathing is there, a little meditation, it comes automatically there. So that is because holistic yoga. If you do physical exercise, not holistic, you are running for, if you do Surya Namaskar, everybody knows what is Surya Namaskar. You do Surya Namaskar like that, breath is, you are doing movement, breath is somewhere else, mind is somewhere else. It is not Surya Namaskar, it is physical exercise. But when you do bend and breathe, by the time you are down, you have breathed in, come up, slowly. And then mind is also there. So movement, breath and mind, that yoga, physical yoga. That yoga is different. Samadhi yoga is Atma Paramatma. This is the physical yoga. Yoga between body, breath and mind. Psychosomatic yoga. That is yoga. That is impact. That is no comparison with any other lifestyle. And lifestyle is also, see, lifestyle is Ayurvedic point of view. They say Ahar, Nidra, Brahmacharya. There. Brahmacharya is there, we don't take much Brahmacharya. Brahmacharya has a different meaning, isn't it? For Ayurveda, very important. First Ahar, then Vyayam. Ahar, Vyayam, Nidra, Brahma, these four are Ayurveda. But you know, our lifestyle, there are so many factors are there. Management of stress, non-smoking, so many points are there, lifestyle.
Yes, sir.
And as a medical college point of view, we are handling students. First point which I observed, first modification of lifestyle is maintaining the punctuality. You said students coming to the class or wherever the hospital, they rush, they wake up at 7 o'clock.
No.
There starts. They may not take breakfast. Your HPA axis is affected there. Sympathetic system goes up. Atherosclerosis starts there. And then they sleep at 1 o'clock. Once in a while it's okay. So they're on daily basis, on daily basis, the lifestyle modification starts there for students. So,
in fact, we did a study on this, breakfast skipping. Many students are skipping breakfast. I think it's a very important point here. To be able to be regular with your diet, sleep, and therefore It's an important intervention point that we have. Of course, we have gone.
9 o'clock, 10 o'clock, because your hepatic glucose output starts by 9:30. So because steroid levels goes down. So once the hepatic glucose output starts, whatever you eat, it will go to the tummy. So that has to be, I think we have to start from there.
Just one point, because before I forget, talking about lifestyle, one very important chronic disease which we should mention to the audience is obesity. I think obesity is going to be the future disease.
It is.
All our children are obese.
Metabolic syndrome.
Metabolic syndrome, obstructive sleep apneas, right.
That's a major point of concern.
Yes.
When I went in 2000, when I went to Delhi, I found many of the school children were really obese. And I thought, oh, this is a Delhi phenomenon. But then when I returned back to Pondicherry, I find this institution, many children are obese. So that is something we really have to focus on. The world has changed. That means we are also catching up with Delhi. So some intervention should be there.
I think, yes, sir.
Yeah, please.
This is actually something that earlier when we were doing work at JIPMA, we were working with the Indranagar students.
Just a few points here. 2 points. Obviously, you are talking about 25% young people also. When I was a young boy in senior, in my school, in my neighborhood, I have not seen a single boy who was obese. But you can see 50s. I am born 47. I have not just, I have not a single boy in whole school, many schools in my neighborhood who is obese. Now, you go to central school, 25% obese are there. 1 point. I have gone to Sikkim for conference for 2010. That was in 2012, I was at that time. At the Gangtok, I have seen hardly any obese person there. Sikkim, hardly anyone who is obese there. So that is the climate, and they have to walk some points of this point. 1 point I want to say about lifestyle.
They don't have McDonald's.
1 point I want to say. See, Ananda, this point we are not emphasizing from Ayurvedic and Yogic point of view. When you talk about food, exercise, sleep, lifestyle, sattvic. Use the word sattvic sleep, sattvic diet. Sattvic also there is a lot of confusion. No meat, no this sattvic is another. Bhagavad na ayush sattabala sukhapriti vardhana. That is sattvic. That is different point. It's a long discussion about this now. Sattvic lifestyle, sattvic exercise, sattvic yoga practice also. Like doing this asana. I have seen now, we have seen the yoga also now. Very tamasic yoga. Isn't it? Sattvic, it should be. Yeah, it's happening now. So that point.
Rajasic yoga, tamasic yoga.
But I'd like to share some personal experience with this, both obesity and though he was my very colleague.
Very smart.
No, very cool. Yeah, that would be nice. Yeah. My colleague, my children, our children have studied together. He always used to tell me, do yoga. I never did. And finally, only when I broke my leg, I had to think of yoga. So, but then it made a difference. And first of all, I started developing back pain. Why? As usual, as Indians, we tend to put on a lot of flab here. The minute I could not sit down after fracture, but the minute I started, no amount of swimming or anything helped. The minute I started doing yoga, within 3 months I could sit cross-legged. Most important thing is that the flab around this, what is called the tummy, that came down drastically, 3 notches in the belt. I think unless we suffer ourselves, we start doing it ourselves, we tend to ignore what is normal. As therapeutic is different, because then he thinks that is something which is beneficial. But as a regular practice, yes, it did make a difference. Something else I noticed, he was mentioning about Surya Namaskar. We do regular walking, but the amount of, what shall I say, cardiogenic exertion with 3 Surya Namaskars is much more than for taking a brisk walk for 45 minutes.
Very true.
So this only because I had the knowledge of both, then that is a physiology. I find just 3 Surya Namaskars. Dhanush is not here. He does Surya Namaskars very fast. And we used to ask him, please slow down because it's too fast. Shobana will share with that with. Okay.
Actually, it's very much something that, we need to actually experience. Many of these things we have to experience, and then only we will be able to...
I would like to give one more experience of mine. I had, my mother expired when I was there, and I had a lot of tension. I couldn't go in time. I got arthritis, both the knees. First one knee and the next one. For many months I had arthritis. I was in GIP at that time. I could hardly walk. So much. Now I have not taken single tablet for that, no treatment. Physiotherapy bit, not that was so much. Now I sit for Padmasana for, that was not 10 years back. I sit Padmasana at least half an hour, full Padmasana, that is there. But you have to exert. That's there, you need to, that's there.
So, but at the same time, I think we have to also be careful we don't try to market yoga as the answer to all the ills. Because I think this is happening today. And that is why we have to have a proper, unbiased attitude that there will be people who respond to yoga, but there may be people who don't respond also. Just as in medicine we have non-responders, we find in yoga some people just don't respond
not only
to
that,
it.
see, I have taught a lot of medical batches in this JIPMAR. I have seen sometimes the students will be there. Within 2 days, some students are able to do Shirshasana. They will not be able to do half Padmasana up to after 1 month also, and vice versa. Some people go such as Shavasana in jail, they enjoy, some go sleep also, of course. Some are rest they cannot do. So various they are normal also, patients also.
So because
when
we want to take yoga into the medical system, as is being done here at SBV, and thanks to our management, thanks to our administrators, our leaders, we are able to take it into the nursing college, the medical college, the dental college, and now engineering college has also joined in. But the question comes, when you take it into these places, they want hardcore evidence. The scientific world wants evidence. They want controlled trials. And I think that is where we are still lacking, because there's a lot of yoga research. But at the end of all the reviews, one line will be put that further work of better quality needs to be done before actual recommendations can be made. We still end up so close yet so far, or so near yet so far. And this is something that I think in institutes like ours, we have to develop maybe better evidence for that to happen.
This point, there's a few points like control trial and this one. See, the one point that the yoga, even not therapy only, yoga as such, for medical people is the best. We understand physiology, we understand this one. That's a very fortunate that you are there. As a physician, eminent, as a yogi, it's a boon to us, isn't it? It's for medical people. Now about the control trial at start. One time, Mrs. Trivedi was this psychiatrist, JIPMAR. A person came wrong back. A person came to me, I can stop my heart, I can change my brain waves. I don't know him. I know you, I want to, some elderly person, I don't know him. He suddenly came. Can you study on me? And then we heard that EEG apparatus was in this cardiology department with Narayan. He used to operate it. So I thought, okay, let me do the EEG. Now this fellow has come, he's going back. Now this is an opportunity. And I went to, Madam was in the OPD, this OPD there, so Madam is there, let us do some study. Same thing, what is the control, what is done, how do you do, what is the before, like that. She said, I said, Madam, this is there, just one study, is there, like that. She didn't listen. Then he does it. Now see, Renuka, Renuka movement. That fellow, he was, this one, Renuka, he ran naked. What is the control? The gravity, Newton. Why the control? Why the project? This is how I done in the beginning of work in Japan. Everyone was, but you cannot do work, I was doing like that. I had a lot of difficulty. What is the control? The KQ discovered the Benjamin wing. What is the control? All rishis, what they have done, rishis with us. All astrology, astronomy, how much accurate is there? What equipment they had? Mind. What control they had? Control is fine, stats I like, it's okay, but it is secondary. It is not the primary. It should be supporting. Primary is this, actual science.
At least they didn't have to face the ethical clearance.
No, I think the obsession with randomized control trials as the only bit of evidence is the problem. And I think as a research body, in fact this was a question I was asking MPH students who are in JIPMA. They have a course and they have had training in this, and many a time they are trained for a randomized controlled trial. Many of the MPH students were Ayurvedic students. So I asked them, okay, this question in the exams I asked them, what is the philosophy of Ayurveda? How do you approach it? How do you decide that this is the treatment? Then they took them by surprise, because that is completely contrary to randomized controlled trials, because it fits that therapy or to that person, treatment to the person. And then they were describing how they actually decide on whether a treatment is valid or not. They have this system of collegium, where the group of experts, Ayurveda experts, they sit together and then they decide this is, and they come to a consensus, about a consensus form. So for a given condition, for a person, one thing may have worked, another thing, something else may have worked. So I think there's a lot of strength in these systems. And we should, as a body, move away from this so-called randomized controlled trials. Where's the control? Where's the evidence? Evidence is there. I am evidence.
No.
You are evidence.
It's true.
You are the best evidence possible. Right. So he is very able to
put this
70 years. Yeah.
label and put in the site.
So now,
What else you want?
Very true.
should we be in the dustbin as evidence?
Yes.
So I think that's because this is something which I've been putting across. There is role for other types of studies. There is role for qualitative studies. Let's look at that and build up the body of evidence so that we can convince others by different method. What is required is whatever we are doing, there should be some rigor of having, and that is where we lack. And another point I would like to make is this differentiation between what you had said is, one is on the preventive aspect and the other is curative aspect.
Yes.
Now, curative aspects, yes, we need evidence like this, maybe randomized controlled trials and all, but on the preventive, like training nurses, training engineering students, I think there we have to build what is a cohort. Follow them up and see what is, first of all, what is they able to adhere to something, and that's a difficult task. So on the long run, then we will really have the evidence that those who adhere to any form, I'm not talking of only yoga, any form of regular, maybe it's meditation, it may be chanting, whichever form they would are comfortable with, and they then see the end result of what happens to them 5 years down the line, even immediate, 2 years down the line, the academic performance, we've been working with our counselors on that, whether that improves or not. I think this is the body of evidence we really need to build up.
Speaking of the rehabilitative side, maybe in cardiology, is there a window for yoga?
Yes, definitely. So that's what. Instead of curative, I would put as rehabilitative. Because rehabilitation, curative, both are inclusive. See, when we say rehabilitation, only if it cures you can rehabilitate. Definitely, there are standard protocols. In fact, there was one study between UK and us having, because of some ethical problems, we couldn't do that. But still, we have definitely yoga therapy has a definite role in rehabilitation, which we are facing in and day out, especially after myocardial infarction, after cardiac surgery. I have lot of situations in hand. I can give a lot of examples. After a bypass surgery, one patient came. In fact, he is one of the husband of a staff nurse. He came just like walking like a stone. I said, why are? No, sir, I underwent bypass surgery. So we do bypass surgery because you have to do a normal routine lifestyle. That's why. So they don't have that habit of knowing what to do. I think rehabilitation, from my point of view, because we have people from lower caliber, low socio-economic status. So we have to have that rehabilitation so that they can go back to their work and earn their money. So we have
that's where the nursing.
We have to collaborate in such a way.
They can come in because they are the ones who, when the person's going back home, are going to tell them, you can be like this, you can do like that. I think
like as we heard of palliative care.
Yes.
What is when we say the word palliative, immediately we think of cancer.
Yes.
It is not that true. Palliative care is for all the diseases. Same way as a protocol, rehabilitation should be there for all diseases which causes restriction.
Yes.
As sir said, after CABG, the patient is restrictive. As like after the surgery, patient should be all right.
Yes.
So where this restriction comes, this is all what they have learnt. As a protocol, there should be one rehabilitative part along with the curative strategy should be there as a protocol in every treatment. Where nurses play important role, not only physiotherapists, team members play important role. Counselor, dietitian, nurses, physiotherapists in all the way to get rid of it and go for a productive lifestyle living.
And the doctor.
After the curative.
That is a major problem. The doctor stays out of that.
Can I add a point? I think cardiac rehabilitation, I think the hot word in COPD management as on date is pulmonary rehabilitation. If you take any journal, any textbook, if you say pulmonary rehabilitation, especially for stage 3, stage 4 COPD, it basically defines it's a team-based effort, putting back the patient to the best possible lifestyle he had before the disease onset. So that is the concept of pulmonary rehabilitation. And just I want to share one interesting study. In pulmonary rehabilitation, what we basically do is, apart from lifestyle modifications, drug treatment, exercises. Basically we do shoulder exercises, walking exercises, all those things. But there was an interesting study in All India Institute of Medical Sciences, published in CHEST 2015. Dr. Guleria has done the study. He compared yoga therapy in one arm with other components of pulmonary rehabilitation with conventional pulmonary rehabilitation. He found that yoga therapy with pharmacotherapy is as equal to the full-fledged pulmonary rehabilitation. So we did not go for an expensive pulmonary rehabilitation program. Simple yoga therapy with pharmacotherapy, it takes care of your COPD patient. So that's very important aspect I want to share with you.
As a rehabilitative part, when people with a chronic problem comes over to yoga therapy, the first thing that, through these simple asanas and the pranayama practices, the first thing that we would like to help them is to face the problem, accept it and face it. Not just face it, how do you combat with it? How do you fight back with that? Oh, is that the mic? So how do you face that? How do you take responsibility? How do you find means and ways? It is not just the medicine that is going to cure it. That is a part of it. But you have to, take responsibility to do something so that you will be able to come out of it and manage it in a better way. Instead of identifying, with the suffering, like VC sir was saying today, salutogenesis. The concept of, instead of identifying yourself with the illness, identify yourself with the wellness. Give them hope. Give them the courage that they can face it. And, like we say, hold the bull by its horns. And it's like, that is the main part where we are, I think yoga would help in these problems. Empower the individual so that they will be able to manage themselves in a better way, whatever problem they are undergoing.
Yeah. I think sort of, concluding this excellent panel discussion, if you want to leave our participants with a take-home message, what is it that each of you would like to share with them as a short take-home message? An SMS. Yes, maybe you can just start, or the other way, whichever.
The change in attitude, that I would say brings a lot of change, the change in perception. Because as you all know, the problem starts with, the way you perceive it, the way you look at it. Like we say, the HPA axis, everything starts with the problem getting triggered, the hypothalamus getting, the fight or flight or the freeze mechanism, and everything starts over from that point. So if you are able to change the way you perceive it, if you perceive it as a problem, as a threat, then you react. The stress response is triggered. So if you don't perceive it that way, can we accept the problem in a proper way? Accepting means not just getting resigned and say, okay, I have this problem. No. But not in a passive way, but in a dynamic and active way, how are you going to address and change and, refine the whole thing, readdress the whole thing. So that way, like the acceptance is going to help them manage the whole thing lifelong. And maybe that is where yoga comes into, to trigger the relaxation response and to change the way they perceive, to change of attitude. Through all these, they are able to handle this, as a chronic disorder or as a lifelong problem. They would be able to handle it in a better way.
She writes long sentences.
I have two things to tell. Make yoga as part of your life for yourself and for others. This is one message. Another message is live with nature. When our forerunners lived with nature, they were healthy. When we go beyond nature, we are unhealthy now. So start living, come back to the living with nature. That is what I like to say. Thank you.
So yoga for patients and caregivers also.
Yes.
Whether the caregiver is a family member or a nurse. Fine.
Yoga is not about complex asanas. I think that's the biggest confusion.
Yes.
So start with simple asanas.
Very true.
Maybe in 3 months you can do Shirshasana.
I feel changing attitude among doctors to accept the fact that integrated medicine should help the patient, not a cardiologist should believe that this also helps. As a concluding message, I want to thank for the opportunity given to me. I thank wholeheartedly Dr. Ananda and Dr. Meena and the whole organizers for giving me the wonderful opportunity to speak about yoga.
I think to add on to Dr. Amirtha, Ganesh, attitude change and a mindset change among the doctors should be there. I think we are not living alone. Those were the days that doctors' words were the thing. Now people have internet with them. They always come with a diagnosis, right? So, and ask us multiple questions. So be prepared for an integrated approach to any disease, especially with chronic diseases. Thank you.
Deserve a very big round of applause. It's been a very wonderful afternoon with them sharing all the experiences, and I request Professor J. Ganesh sir to give away the mementos on behalf of the organizing committee to our panelists, each and every one of them an eminent person in their own field and coming together with joy to share with you, honoring Professor Madanmohan sir, Emeritus Professor of Physiology and Yoga Therapy, the founder director of CYTER, CYTER, and now we are honoring you, sir, for your participation. Invitation for next year's. Professor K. Narayan, sir, with a memento on behalf of the organizing committee. Sir has always been a great supporter of our work at CYTER, and both him and Pushpa ma'am have added so much of life to CYTER on many occasions. Honoring our Professor Amirtha Ganesh sir on this occasion. As I said, maybe little later we can ask him to sing a song, because he sings and heals his patients along with his cardiology skills. Honoring Professor Pajanivel sir, who has been so kind to take up 2 of our MPhil students and doing the work in COPD and in diabetic lung. At present we are doing with sir. A very special heartfelt thank you to Professor Renuka ma'am, who is so supportive of all our CYTER activities and responsible for bringing yoga into the nursing curriculum, something that is very unique. And of course, Dr. Meena Ramanathan, Deputy Director of CYTER, and the one who keeps CYTER moving forward from day one.